We will now discuss bony pathology of the hip. As you learn more about the hip, you will find that age of the patient helps with differential diagnosis. In discussing more bony pathologies this time around, we will see our age demographic increase a bit. Hip fracture is highly prevalent in geriatric care, with 500,000 cases a year expected to triple by the year 2050 and place a $6 billion burden on society. Of all fall-related fractures, hip fractures lead to the greatest number of deaths, reduction in quality of life, and prolonged hospital stays. The most common mechanism is a direct lateral impact via collision or fall, with the most common sites being in the neck, intertrochanteric area, and subtrochanteric area. Associated risks include soft tissue damage and hemorrhage. Treatment options include open reduction internal fixation, external fixators, arthroplasty, hemiarthroplasty, or non-surgical options. This is a reference slide classifying fracture types, common surgical procedures, and weight-bearing status after that procedure. Looking specifically at femoral neck fractures, we see a risk of the blood supply being compromised, leading to avascular necrosis. Mortality is unfortunately high with dislocation of a fracture, and rehabilitation needs to take place early in this group. Though still serious, there are less risks associated with intertrochanteric fractures. Physical therapy of most fractures include early mobilization and goals that focus on cardiovascular fitness, strength training within the precautions of surgery. Hip dislocations are another pathology that occur with trauma, whether they be compression or rotational traumas. The most common direction of dislocation is posterior, and the associated risks include damage to the sciatic nerve and compromise of the blood supply. As mentioned earlier, the consequence of a poor blood supply is avascular necrosis or death of the bony tissue, which often necessitates a hip replacement. Avulsion fractures are a different subset of fractures caused by a violent contraction or tractioning of the muscles commonly seen at the ASIS, AIIS, lesser trochanter, and ischial tuberosity. Signs and symptoms include pain, bony point tenderness, swelling, and muscle bulging away from the attachment. Hip OA is a very common diagnosis that you will see. These guidelines are great to refer to while you are out in a clinic. Degenerative hip changes are the most common reason individuals over the age of 50 seek treatment. These changes are often due to repetitive trauma, age, acute injury, and/or obesity. Specifically, hip OA is operationalized by the progressive deterioration of the articular cartilage, capsular fibrosis, and osteophytes due to idiopathic or traumatic mechanisms, along with alterations of biomechanics, as well as congenital abnormalities and FAI. Signs and symptoms include anterior groin pain that may radiate into the thigh, or the C sign mentioned earlier. Other signs and symptoms include stiffness after prolonged rest, decreased range of motion into extension, internal rotation, and a loss of end range flexion with a firm end feel. Gait may appear antalgic with slower speeds, and patients also present with a loss of quad strength. This is a slide to spend some time on. It would benefit you to committing these clusters to memory. Cluster number 1. If patients present with hip pain and have hip internal rotation less than 15 degrees and have hip flexion less than 115 degrees, their likelihood of osteoarthritis is very high. The second cluster is for patients that have hip internal rotation greater than or equal to 15 degrees. In this cluster, if patients have painful hip internal rotation and are over the age of 50 years old and complain of hip stiffness in the morning that lasts less than 60 minutes, there is also a high likelihood of hip osteoarthritis. We also have a clinical prediction rule to help identify individuals with hip osteoarthritis. If 4 or more of these factors are present, there is a 91% chance the patient's source of symptoms is hip OA. In fact, if they meet 3 out of the 5, there is a 68% chance. And looking to our most recent clinical practice guidelines, we see a diagnosis of hip OA in those over 50, having anterior or lateral pain during walking activities, morning stiffness less than 60 minutes, hip internal rotation less than 24 degrees, or hip internal rotation and hip flexion 15 degrees less than the contralateral side, and or hip pain with passive hip internal rotation. Our exam of these patients should include functional performance measurements, as well as look for impairments in strength and range of motion. Conservative management is recommended as the first line of defense and should have the goal of minimizing pain with medications and physical therapy to address impairments in mobility and strength. It should also include education on activity modification and weight loss. A study was done in 2004 looking at the effectiveness of manual physical therapy versus exercise in patients with hip OA, based on meeting the Altman's criteria you learned earlier. Patients received manual therapy or exercise for 5 weeks. Those receiving manual therapy underwent stretching, traction, followed by manipulation, while the exercise therapy group included strengthening of major muscles, stretching, active range of motion, and walking. This slide shows the patient position being in a loose pack position for the manipulation. You will learn this technique in lab. As seen by an improved score of the Harris Hip Scale, those receiving traction manipulation outperformed those receiving only exercise. In fact, 81% of patients improved with manual therapy versus 50% with only exercise. This lasted 6 months after treatment, thus leading us to conclude manual therapy provides better outcomes than exercise alone, though exercise does remain important. Here we see a systematic review favoring manual therapy in this population. In identifying those who are likely to respond to physical therapy, we have this clinical prediction rule. If a patient meets 3 of these factors, we have a 100% likelihood of improvement with physical therapy. In fact, those that met at least 2 of those criteria had a probability of success with PT of 65%. Moral of the story, try conservative management first. The next 2 slides are for your reference as they show many options of manual therapy and an associated home exercise program to the hip and the spine in patient management. You will learn some of these techniques in lab. Moving to total hip arthroplasty, we see the first introduction in the 1960s, with the outcome being one of the most successful surgical interventions ever developed. The goal of total hip arthroplasty is to improve hip joint stability, mobility, locomotion, and patients' quality of life. We are seeing more and more patients receiving this intervention due to the aging population and obesity epidemic, with an expected 570,000 initial surgeries to be performed by 2030. We are also seeing a different patient demographic that are creating a change in surgical technique, thus requiring adaptation of rehabilitation. We are seeing patients much younger. In fact, those under 65 are projected to represent 50% of those receiving THA. Indications for this surgery include OA, RA, poorly healed hip fractures, avascular necrosis, congenital abnormalities, and pain not relieved by conservative care. Contraindications mostly include active infection and poor bone and muscle quality. Post-op care is being revolutionized. Patients are now admitted the morning of surgery and mobilized that same day. They are typically weight-bearing as tolerated, and length of stay is much less than 5 degrees on average. There are many forms of hip arthroplasty depending on patient need, and you may use this slide for your reference. There are also several types of approaches, each with advantages and disadvantages. Many surgeons are electing an anterior lateral approach due to its lower risk of dislocation than a posterior approach. The main disadvantage to look out for in the more anterior approaches is the predisposition of hip flexor tendinitis. We also need to be aware of the procedure being cemented versus cementless, with cementless being the most commonly used currently. Cementless allows for biological fixation or bone ingrowth within 3 to 6 months. Cemented are reserved for the elderly and those with low levels of physical activity. Though the surgery is very successful, there are some complications to be aware of, including DVT, device failure, leg length discrepancy, malalignment, infection, improper fixation, nerve palsy, dislocations, and periprosthetic fractures. Many patients are under precautions depending on the procedure performed and surgeon preference. The most common precautions are ones to commit to memory, are the ones most commonly associated with the posterior approach and include no hip flexion above 90 degrees and no internal rotation. If the approach was done anteriorly, typically we follow no hip external rotation. These precautions typically last for 3 months. You may use this chart for reference. The biggest reason for these precautions is hip dislocation, which occurs most often in the first year after surgery, though at a very low rate. Those at highest risk are females with poor bone quality. At times, patients may require revision surgeries due to age upon initial surgery, device failure, infections, instability, or fractures. Those rehabilitating after will be under tighter precautions and have the potential of extensive scar tissue. This is a busy slide, but the big takeaway is that post-op physical therapy is neither supported nor denied. However, surgeons are now telling people to walk versus receive physical therapy. No trials have been done to determine the most effective rehabilitation protocol. However, Dana Judd and our lab are currently in the middle of one to determine best practice. We do know that patients after total hip arthroplasty commonly have long-term biomechanical abnormalities that do not improve without intervention, so we have theoretical rationale for our benefit postoperatively. Many patients improve to baseline initially. however, start to digress after 6 months post-op. Our trial currently is comparing usual care to an intervention group of lower abdominal strengthening, high-intensity strength training, and balance focusing on pelvic stability for 8 weeks. In general, our role during examination of these patients is to gain information on surgery performed and current pain management strategies. We also need to perform an ongoing assessment of post-op complications. Treatment should address impairments, realizing that they may need a longer time in rehab to reach full potential. You may use this slide for inspiration of post-op exercises. Some healthcare systems cover preoperative classes, including educational sessions on expectations and sample exercises. The pathway of care for these patients may include a short inpatient stay, less often a stay in a rehabilitation hospital, and most often plans of care in an outpatient clinic. Regarding a home exercise program, we see greater improvements in those who have a high compliance, and note that performance should be recommended for 3 days a week. This slide shows the superiority of strength and postural stability exercises over basic isometric strength and range of motion. The next few slides are for reference to post-op care ideas. It is important to consider and set expectations for sports activities, which you will find listed here. However, please consult with the surgeon, as many have different preferences. Another question you may receive or item you may want to address is resuming sexual relations after THA. Many surgeons recommend waiting between 1 and 3 months. It is our job to work with the patient in their ability to identify safe positions postoperatively. There was a push for minimally invasive surgeries to allow for earlier discharge and a shorter rehabilitation. However, newer protocols for pain management and rehabilitation have a greater influence on discharge than length of the incision. Thus, many surgeons elect for an incision that allows for a full visual field of the joint. And finally, a common variation of total hip arthroplasty is a hip resurfacing procedure reserved for those who are physically active and under the age of 60 with hip OA, AVN, or dysplasia that have good bone quality that is strong enough to support the implant. The goal with this is to preserve as much of the bone as possible while improving the weight-bearing surfaces of the bone. For a more personal story on this, you may refer to this case or ask Paul about his experience. This concludes our lecture on bony hip pathology. Again, please don't hesitate to contact me with any questions or concerns you have with this material.